Hello. Uh, this is the second module. I'm going to record a number of modules and put them on YouTube on the use of nitrous oxide. And so this is 102, or the second module. We're going to talk about scavenging nitrous oxide for trace contaminants. This is a topic that I get phone calls from on a fairly regular basis, either women dentists or women dental hygienists or dental assistants who are either pregnant or thinking about getting pregnant, and they've heard about the problems of being exposed to trace contaminants in the dental office. I put this program together, I guess, maybe 12, 13 years ago, and had a paper published, which we'll refer to here in just a second. This is sort of the announcement that you'll find on the first of all these modules. Some people have asked if they can get CE credit for watching the presentation. Hopefully you watch it because of the information that is in the presentation. It's the same presentation that I've presented many times for various dental schools and or other continuing education programs. I realize this one was recorded in May of 2016. Things do change, discoveries are made. The material may not be valid next month, but it's been valid for the last 13 years, so I think it'll last for a while. Secondly, I am a general dentist, although I did a residency in anesthesia, and my emphasis in this information will be the information that is needed by general dentists as opposed to strictly academic presentations. So the first thing you should do if you're considering getting credit for it from your board is to check with the board and see what they accept. I checked here in the Pacific Northwest. Washington State's dental board accepts up to 7 hours of CE online. Oregon will accept more hours, but they only accept them if there is a test that goes along with the presentation. And I do have a quiz that I will email you if you need that. And Idaho seems to accept online courses at face value. So to prove that you'd paid attention while watching the video, I prepared a 10-question quiz. It's not particularly difficult. And you always have the ability, if you get the test and you don't have an answer to one of the questions, you can go back to YouTube and watch the program a second time. To get the test, you need to email me, fredq@comcast.net. I will email back the test, complete the test, and if you want credit for it, send it along with a $30 check to seconddentalopinion.com, 5767 South Oaklawn Place, Seattle, Washington, 98118. I will grade the test and return it along with the certificate of completion. And if you have any questions about all this, my email address is, again, fredq@comcast.net. So we're going to be talking about the scavenging of trace contaminants and nitrous oxide in the dental office. We'll talk about the issues, and I'll also show systems that have worked well in scavenging trace contaminants. In August of 2005, I had this paper published in Dentistry Today. Realize that's not the greatest academic journal in the world, but it got into great detail of what we know about the trace contaminants, what levels are necessary to be safe, how you can go about achieving those levels. And you can find this online. Just go up and search dentistrytoday.com and then search for Quarnstrom. And this was published in the April 2002, I guess it was, issue. I guess maybe it was written and was posted in 2005. So it's been there for a while. Well, let's take a look at occupational safety, which is really the grand topic that this all falls in. When did certain occupations turn out to be a problem? Well, in fact, they found a high incidence of scrotal cancer in English chimney sweeps. Obviously, the sweeps in cleaning out the chimneys got their clothes sooty, and soot in the chimneys had all sorts of chemicals in it. Next, the dry cleaners were found to have a high incidence of liver disease, and this was singled out as a problem with the carbon tetrachloride, one of the chemicals they use in dry cleaning rather. Chemical workers that worked with benzene were found to have a high incidence of bladder cancer. And then medical workers that worked around x-rays had a higher incidence of cancer and spontaneous abortions or miscarriages than the general medical practitioner had. So this highlighted some areas where we need to be careful. If we look at anesthetic gas problems, Lassen in 1956 showed that the anesthetic gases that were used in operating rooms depressed bone marrow, which was a concern. Smith in 65 showed an increase in animal fetal mortality. So in animal studies, their fetuses, some of them died. And a good friend of mine, David Donaldson, did a study with nitrous oxide a little after this, was probably in the 1970s, where they took lab animals and exposed them to quite high levels of nitrous oxide during their pregnancy, and they found some of the fetuses were born missing digits on their paws. There was a number that had cleft palates. Some had other fetal problems. Their litter size was smaller than normal. But remember, he was using rather high levels of nitrous, and in a second group, they added some cortisone, which tends to accentuate any sort of problems from this toxicity. But in doing so, he showed there really was an issue with nitrous oxide. I'm going to probably screw up the next pronunciation. Vassman, Russian anesthesiologist, showed that the staffs working in Russian operating rooms had a higher incidence of spontaneous abortions. In Russia, many of the anesthesiologists were women, so this was a real concern for them. Ashcroft, a few years later in 1970, showed that Western operating rooms had a similar problem. And Corbett in 1973 showed an increase in malignancies in ORs. And initially, we thought, well, this is probably the halogenated hydrocarbons, the halothane, the penthrane, the ethers, that and other chemicals in the operating rooms. It might be the level of stress. It could possibly be the agents they used to sterilize operating rooms. So they didn't single out any particular drug. Now, Bruce did a study in 1974 that we will refer to a couple of times. He took volunteers. He was working in Salt Lake City, and gave them a couple of mixtures. One was 500 parts per million of nitrous oxide. Another was 50 parts per million nitrous, along with 1 part per million of halothane. Halothane is a very potent general anesthetic. It will put you into general anesthesia at about 1%, 1.5%. It's one of the drugs that I learned to use in my anesthesia residency. A number of people tried to repeat that study without success. They couldn't show what he had shown. And eventually he left Salt Lake City and was on the East Coast and repeated the study and couldn't show the effects either. And he wrote a retraction letter of the study, which we'll see here in a couple of minutes. He didn't feel it was a valid study. Cohen, in 1975, looked at the effects of nitrous oxide in that dentistry was a fairly unique group to study this because we either used nitrous or we didn't use nitrous. And in those days, with the exception of oral surgery offices, that was about the only general anesthetic drug that office staff was exposed to. And we'll see Cohen's results here in a minute. But to sort of steal some of the thunder, we had a problem. Kripke in 76 showed that it depressed sperm count in males. It's not an effective way to use contraceptives, but it did have effect on the male dentists, and you're going to see some evidence that it had effect on their wives when they got pregnant. And then finally, Sweeney in 1985 did a study that gave us some good ideas as what safe levels were. So let's look at Bruce's stuff. In 1983, he said, There is no longer any need to refer to our conclusion as controversial. They were wrong, deprived from data subject to inadvertent sampling bias and not applicable to the general population. What he had done was he'd used the favorite lab animal, namely students. They work cheap, and the students he found in Salt Lake City were, for the most part, members of the Mormon Church, and as such, they didn't and weren't exposed to stimulants or sedatives such as alcohol, and so they really didn't represent the general population. What he showed in his study that 50 parts per million nitrous with 1 part per million of halothane affected them in some very subtle neurologic ways in their reaction time. And I believe it was flicker fusion tests where they flash numbers up for literally hundredths of a second on a screen and then ask people to recall those numbers. And he did find a statistical difference. But when he redid the study with on the East Coast, where the population represented the normal population, not those who had not had sedatives or stimulants, he couldn't show any difference. He did start to see a difference in reactivity at 500 parts per million. NIOSH, the National Occupational Safety and Health, National Institute of Occupational Safety and Health, came to him before his paper was studied or before it was published. They'd heard about it, and they took a look at his data, and out of the 50 parts per million, 1 part per million halothane, they then suggested that the maximum exposure that dental assistants, dentists, dental hygienists should be exposed to is 25 parts per million. And in this statement, in his retraction letter that was published a couple of years later, he suggested that the conclusion was controversial and the NIOSH standards should be revised. It's important to notice from the first effect seen, it was 50 parts per million of nitrous combined with 1 part per million of halothane. We've talked about a very potent general anesthetic. The lowest level that he saw anything with just nitrous was 500 parts per million, and that had borderline statistical findings. But the study was titled Anesthetic Effects on Perceptual, Cognitive, and Motor Skills, and NIOSH came out with an alert bulletin suggesting we should stay below 25 parts per million. They were wrong. It was derived from data that was subject to inadvertent sampling bias and not applicable to the general population. So where does all this happen? What goes on? And if we look here, vitamin B12 is necessary for methionine to be changed into this form of methionine, which eventually comes down here and is transformed into DNA. Nitrous oxide blocks the vitamin B12, and there's been some suggestions that ladies that are pregnant should be taking extra vitamin B12. There's no evidence that it stops, that helps with this synthesis problem. So if you're exposed to nitrous oxide, it can decrease your fetus's ability to make DNA. And of course, the fetus in the pregnant patient is very busy with cell division as the fetus grows in the womb. And so this is a major problem if we don't control it. And the question was, how much nitrous was a problem? So they did some studies. This is a study where they looked at methionine sensitase, hard word to say, activity, and showed here it was 80% effective at this level of exposure. What does these units mean? It's the percentage times the number of hours of exposure. So if the lab animal was exposed to 50% nitrous for 10 hours, it would be clear out here at 500. If it was 10% nitrous for 10 hours, you would find this sort of depression of the methionine sensitase. And you can see in rats and mice, clearly there was a relationship between the time-weighted average of exposure and the methionine sensitase activity. In humans, it wasn't quite as stark, but it clearly indicated here that we had much the same problem. So when we looked at Cohen's study, he looked at offices that used nitrous 1 to 8 hours a week and more than 8 hours a week. And this was done with a retrospective study. He literally sent out thousands of questionnaires as to any medical problems that had occurred in the dental office. And out of this study, statistically, he found that female dental assistants had a higher incidence of spontaneous abortions, i.e., they miscarried more often. And dental wives had a somewhat similar problem, which, although lower, it still is an issue, was the dentist bringing home nitrous in his system that was being off-gassed to the wives. We're thinking from later studies that the dentist's sperm may not be quite as viable in this. Congenital anomalies, and rest assured here, these were fairly minor things, skin spots. It wasn't the children were being born with 3 arms or 2 heads. The dental assistants exposed from 1 to 8 hours seem to have a bigger problem than those greater than 8 hours. When you see this sort of relationship in a study, you get a little bit nervous about the validity of it. But we see here the dental wives also seem to have a somewhat higher incidence of these congenital anomalies. When they looked at liver disease, dentists that use nitrous a lot seem to have a bigger problem. Chairside assistants seem to also. There was some thought that this is back in the 1970s when nitrous was sort of being reintroduced to dentistry, and a number of our colleagues would check the gas daily to be sure that it was still working. They would have a little shot of nitrous, maybe another one at lunchtime to relax them. They also were the movers and shakers that might have been more prone to having a cocktail or two when they got home in the evening, and that's known to be a problem for the liver. So it wasn't very clear how this happened. Kidney disease had a higher incidence in chairside assistants. The dentist did also, but theirs were kidney stones. That's a little bit hard to explain from nitrous exposure, but nonetheless, it was one of the things that came out of the analysis of this very large study. Neurologic disease became a real issue. People who used a lot of nitrous saw some somewhat weird neurologic disease. Now, one of the things I mentioned happened is there were a fair number of our colleagues who were abusing the gas. I got a call one night from a wife who said, hey, my husband's down in the office breathing nitrous. What should I do? And I said, well, I think you ought to call the police and have him taken into protective custody. She said, well, gee, I really can't call the police on my own husband. I didn't know who she was. She hadn't given me a name. And I said, well, I'll be happy to call the police. I'm worried about his safety, whoever he is, but I need to know who he is and what the office address is. So it turns out I knew the fella. She gave me the name. So I called the police and asked them to please go check up on him, and please call me when you get there. It was about 11 o'clock. I wasn't going to sleep well until I knew he was okay. I got a call at about 11:30. The policeman said, yeah, we broke into the office. He was breathing the gas, had fallen asleep, and his oxygen tank had run out. And this was pre-days of safety systems to shut the system off when that happened. So in all likelihood, we saved his life that night. He got into counseling and was able to handle his issue with self-administration of nitrous. But those dentists who did have a daily hit of the nitrous or used it in lieu of alcohol, whatever, if they used it enough, they found that over a period of time they developed some neurologic disease very akin to muscular dystrophy or multiple sclerosis. They lost feeling in their feet and hands. And if they'd stopped using it, they got most of that back. But it was a real battle to stop using it. While it is not probably addictive, they certainly liked it, and they certainly seemed to think it was necessary. At least one committed suicide because he just couldn't get off the nitrous oxide. So here, if we take a look, D stands for dentists, dental assistants, neurologic disease, Both groups had an increase the more they used nitrous. If we look at renal disease, dentists, it's not so clear. Dental assistants look like it may have caused some kidney problems. If we look at liver disease, the dentists again seem to have a problem, lesser for the dental assistants. Developing cervical cancer, a very, very small, if any, result. Uh, Dental assistants with congenital anomalies for their fetuses, it was pretty clear there was a problem. But if we looked at spontaneous abortions, both the dental wives and the dental assistants had a very marked problem with spontaneous abortions if they were exposed to nitrous oxide, even 1 to 6 hours a week. In the case of the dental wives, it was the husbands that were exposed. So Cohen showed that we had a problem we needed to do something about. Here's another study by Rowland where they looked at the ability of dental assistants to become pregnant. They had 4 groups, the unexposed, the low exposure was scavenging, and I'll define that in a minute. High exposure was scavenging, low exposure that were unscavenged, and high exposure that were unscavenged. The numbers here, particularly in this group, are pretty small. And so let's take the next look. High exposure was greater than 5 hours a week. A low exposure was less than 5 hours a week. Same thing with unscavenged, less than 5 hours a week and greater than 5 hours a week. And it should be mentioned, this study was originally done by Rowland looking at the exposure to mercury vapors in offices that used amalgam. And they found nothing. They couldn't see any difference between the staff that was exposed to mercury vapors and the fact that wasn't exposed. But here's the graph, and this is, again, the fecundability. They're studying the ability of the dental assistants to become pregnant. So unexposed is the control, which is the yellow lines. Low unscavenged is the blue lines. High but scavenged is the salmon color. Low unscavenged is the green. All of these showed no statistical difference, but then we had the high exposure, which was more than 5 hours a week, and they did seem to have a problem getting pregnant. This phenomenon is known as fecundability, but it was very small numbers. And in their study here, they didn't show us the standard deviations. And there's some question because of the small numbers. I think it was 19 in this group. The standard deviations might have been great enough that there really statistically wasn't an issue. But at least in this diagram, it sure looks like it was an issue. And what the lower level is here is how many menstrual cycles it took the assistants to become pregnant. And literally 90% were pregnant within a year. And in fact, about 70% were pregnant within 6 months. So these groups here, it doesn't appear that there was any issue. It was only the group that was working in offices that did nothing to scavenge the trace contaminants. Now, we mentioned Sweeney. Sweeney was a researcher who had dentists wear a dosimeter, and we'll see some pictures of dosimeters here in a while. And after a week of working in the clinic, and it was a graduate clinic in a dental school, he would do a sternal puncture to get some of their bone marrow, and with that, he would look at the deoxyuridine suppression scores. And if you look at the numbers, these are the various dentists that were studied. There were 3 here that clearly had a problem. Their deoxyuridine suppression was pretty great. This one is sort of marginal, pretty great. But out of this, he felt that anything under about 1,500 parts per million, you were as safe as the people that had very low exposures. To be super safe, he said, rather than saying 1,500 as a cutoff, anything below 450 parts per million is adequate to avoid the problems of deoxyuridine suppression. Well, let's take a look. This is Sweeney's cutoff point here. In Sweden, they suggest dental offices should not be more than 100 parts per million. The American something of industrial hygiene has said 50 parts per million, which is the blue line. State of Washington somehow came up with 30 parts per million. I talked to the industrial hygienist that was in charge of this, and he said, oh, that was a typographic error. I took him about 6 inches of research papers addressing this issue, all of which said that that was way too low to have as a requirement. And he said, well, I appreciate that, but it's in there and we're not very inclined to change. And I kept bugging him. It took about 2 years, and the state of Washington corrected the typo, and it's now 50 parts per million. In NIOS, National Industrial Occupational Safety and Health Division, stuck with their 25 part per million. They published an alert bulletin that went out to dental offices. They suggested that we might be wearing space suits where we would have a helmet over our heads into which outside air was pumped. A pretty impossible situation to do dentistry in such a device, and particularly since Sweeney showed very clearly that 450 was a very safe level. We actually met one of the dentists who was in this study. How do you get to dentists to expose themselves to a sternal puncture? They take a very large bore needle and push it through the bone of your sternum to get bone marrow. That's tremendously painful. And we asked him, well, how did you tolerate this? And he said, well, I was in a residency program. The pay wasn't great. There wasn't much left over for a beer. So what Sweeney did Friday afternoon, he would take us all to the clinic and collect our badges so we knew how much we'd been exposed to. And then we'd go get the sternal puncture. And after the sternal puncture, he'd take us to the pub and we could have all the beer we could drink. So he said, yeah, it hurt a little while, but we had a very enjoyable evening. So bribery does work. A friend of mine, Dr. David Donaldson, who's professor emeritus at the University of British Columbia Faculty of Dentistry, did some interesting studies. He had a retired dentist volunteer who went out into offices with various scavenging devices and equipment to measure their exposure to nitrous to see what levels could be achieved by these various masks. They'd let the dentist use the mask for a week or so, and then Otto would arrive with the monitoring equipment to see how it went. He also kept track of where you would see spikes in exposure. David and the dental school did study with some of the masks in a more ideal setting, namely the dental school clinic in the summer. There wasn't any dentistry being done, but the dental assistants could come down to his clinic and receive nitrous oxide, and he would monitor the exposure in the breathing zone of the patient, or the dentist and the dental assistant. An ideal setting, since there wasn't dentistry being done. No one was opening their mouth while the dentist was working on it. And he got very, very ideal levels. 9 parts per million is phenomenal. 25, and in one case 180. It was a little harder to explain. But the brown mass that we'll talk a lot about had very good levels, below 50 parts per million. Porter's mask did similarly. Parkel mask is no longer available, is the Dupeco. The comfort cushion was by the McKesson company. It's no longer available. A CO2 absorber, which I'll talk some about, which I learned to use in my anesthesia residency, turned out it was a great scavenger, and it also saves you a lot of money on gas. So we'll talk about that some too. Then Otto looked at when he saw a spike, how come? Well, if the patient talked, to talk you have to exhale air, and that would give a burst of the level of nitrous oxide. A patient moved, the mask seal might be broken, and you would see an increase. If you had a poor mask fit so it was leaking, that goes without saying. If the patient were restless and were tending to move around, occasionally there were technical problems, a hose would come disconnected. If the patient mouth breathed, that would cause an increase in the nitrous in the room, and moved mask. And then if they had a mustache. And so you should shave the mustaches of all your patients. I'm being a little silly. If you have the right size mask, you probably can get a seal even with a mustache. How do you monitor this? Well, the Valtronics device here on the left, I had one to try in my office. And it was really obnoxious and a tremendously loud siren. And particularly in the one room, it kept going off. And I knew there wasn't a problem. I was using Scavenging. I had good mask fits. And lo and behold, I discovered one of my hoses had a hole in it. So in fact, it was telling me that there were higher levels than I wanted, but a really loud siren. This is a device that looks like a fat pen, and it's about as long as a pen would be, that you simply slipped in your pocket. You took the cap off, and you recorded the time here. And then when you were done for the day, you put the cap back on. And the next day, you took the cap off, recorded the time that day, and put the cap back on. And then you sent it in, and they would analyze it to see what the time weighted average. They would look at how much nitrous was absorbed by the pen and relate that to the number of hours that the pen had been exposed. The lower one had much the same approach. This was before the Porter Company got this one. If you bought these, and they run around 50 now, maybe $100, you would always get back good answers from this little barrel-shaped device. And one of the dental schools actually did a study. They exposed the monitor to various levels of nitrous oxide, sent it in for analysis, and the analysis they got had no correlation to the exposure. The fellow who was running the company, they weren't analyzing. They were just sending back good data that looked like the dentist wanted. No one complained until the dental school assessed it. This is kind of an interesting device. Bacharach has a digital readout that tells you your instantaneous reading, what it's being exposed to that minute, which can be great if you've got a hole in the hose like I had. You wander around the room, it's like a little bird dog, and it will find the area where the nitrous oxide is more concentrated, and that could lead you to a pipe that wasn't properly soldered, or in my case, it could have led to this hose that had a hole in it. But it has a second item here, which will give you the time-weighted average, which probably is more important. It turns out of small exposures to nitrous, such as patients get when they're breathing nitrous for, say, an hour, maybe 2 hours, it doesn't seem to have any effect. It's what happens over the 8-hour day or the 40-hour week that seems to be more of a problem. These machines are costly at about $2,000, but they're still available. And in the coal mines, they used to use a canary. If the canary fell off the perch, it said there was lots of methane in the mine, and the miners had better get out of there before there was an explosion. Well, the mine operators felt the canaries were a little too sensitive, so they got these mini gas masks to put over the canaries to dull their sensitivity to the methane. We're not suggesting you dummy up your results here. It's important for your safety as well as your dental staff safety. So how do we go about scavenging? Let's look at some of the systems. Well, initially we all use semi-open systems. Here's our nitrous machine. The gas came out of this pipe. It went into a reservoir bag. When the patient inhaled, they pulled gas out of the reservoir bag down this 22 millimeter in diameter hose that typically was about 1 yard long to a Y piece that you see here that split, so the smaller 11 millimeter hoses went around the head into the mask. The patient inhales. When they exhaled, there was a one-way valve here that prevented it going back into the reservoir bag. We don't want people rebreathing the gas that they exhaled, and that pop-off valve then blew the gas out into the nitrous operatory, right into our faces. It probably kept us a little more mellow in the afternoon because we were getting a significant amount of nitrous oxide. As it turned out, that was bad. The levels of nitrous in the operatories were recorded being as high as 3,000 to 5,000 parts per million. And once the data came out from the various studies, that was too much. So the next setup was an open system, somewhat similar. Patient inhales, out of the bag. There's a one-way valve here. It goes to the mask, into the patient's nose, lungs, etc. When they exhale, this one-way valve prevents them from breathing back into the reservoir bag. Instead, they breathe out this other 11 millimeter hose into a 22 millimeter diameter tube that was a yard long. And we then attached suction to that tube. And I did some research showing was there any gas coming out of this, and in fact the answer was no. Uh, it was a reservoir hose so that when the patient exhaled it could actually hold 2 or 3 breaths. In the meantime, all the patients inhaling and resting between breaths, the suction here took the gas out of the hose so it didn't escape into the room and was dumped outside of the office via your suction system. So this worked, and we got pretty good results with this, right around 50 parts per million. Very simple setup. And here you see, now I cut the long hoses here and here, otherwise it'd be a yard of hose here, there'd be another yard of hose here, and here was the suction device into this reservoir hose, or I just made a little slit and put a saliva ejector there. I did a Y on the saliva ejector, so one end went to the patient's mouth, the other end went into the hose, and I was able to get good levels. The hoses that went around the head obviously were much longer than this, and we had this button that sealed up where the pop-off valve had been. And here you see the actual hoses in their length. This is the part that goes around the patient's head, and I encourage you, take it around their head, behind their neck. Don't go around the chair. If you go around the chair, you're strapping the patient's head to the chair, and they can really freak out if they're apprehensive. And when you turn their head, the mask doesn't tend to go with their nose. Where if you go around the head, you can turn their head, you can tip it up or down. In this case, it was early on. I didn't have an endotracheal tube adapter, so I clogged up the Y here that used to go to this hose with impression material, so that when the patient inhaled, they sucked out of the bag. There was a one-way valve here. It went down to the mask. When they exhaled, because of the one-way valve, they couldn't blow it back into the reservoir bag. It went into the other tube and eventually into this reservoir tube. And here you see my saliva injector that could be attached either here or here. And it worked. The closed system, or semi-closed system, circle system, whatever you want to call it, has a CO2 canister here, a CO2 absorbing canister that has barrel line. So in this case, when the patient inhales, they suck out of the reservoir bag. They draw it through the soda lime that removes any carbon dioxide. It goes down this hose to the patient. When they exhale, they blow back down here to the reservoir bag. Most of what you exhale is very similar to what you inhaled. You didn't change the nitrogen. You used up about 3% of the oxygen and added about 3% carbon dioxide. And if you can remove the carbon dioxide, they can breathe the same gas again over and over and over, which cuts down the amount of gas you're using. There was a pop-off valve here because if you add 1.5 liters per minute, eventually your bag's going to get full and the patient's going to have a hard time exhaling. For that matter, there's a pop-off valve that we hooked up to suction, just figuring it would be a good idea to get it out of the office, and it turned out it was a very efficient scavenger. How does this all work? Well, when we eat food, it's a carbon, hydrogen, oxygen combination, whether it be pasta, meat, salad. We add oxygen to it metabolically in our tissues to make our muscles work, to make our nerves work, all the various functions our body does. And when doing that, our body creates carbon dioxide. Carbon dioxide plus the water in our plasma comes down here to form carbonic acid. Carbonic acid dissociates into hydrogen ions and bicarbonate ions, and I'm sure you all remember in chemistry the negative logarithm of the hydrogen ion concentration is the pH of your blood. So the smaller that number is, the higher the concentration of the hydrogen ion, and it's the hydrogen ions in our blood that stimulate us to breathe. And you knew that. If you breathed in and out of a paper bag, eventually you start hyperventilating because your CO2 levels get higher because you're inhaling your exhaled air, and that means the pH, the hydrogen ion concentration, gets greater, the blood becomes more acidic, and that forces you to breathe harder and deeper. When I was in physiology, we had a study that we did using us dental students as guinea pigs, and I was a guinea pig that got to breathe 10% carbon dioxide. I emptied a whole garbage can of air in about 55 seconds. I just couldn't breathe hard enough and fast enough. It's a phenomenal stimulant to breathing. By the same token, if you hyperventilate, breathe hard and fast, you can blow your CO2 levels down. Your pH then becomes more basic, and you don't have a particular desire to breathe. So that's how the CO2 absorber works. It absorbs this CO2 so you can rebreathe the same gas. So here we are breathing in 80% nitrogen, 21% oxygen. When we exhale, 17.5% of our exhaled air is oxygen, which is how mouth-to-mouth resuscitation works, and about 3.5% of it's carbon dioxide. If we can remove the carbon dioxide, we can basically rebreathe the exhaled air. And so the CO2 absorber cut down a lot on the amount of gas we used, and because of the pop-off valve, it turned out to be a very good scavenging device. Here is a couple of the units that I used. This had a clear canister. You can see some of the barrel lime. That would normally be full. There was a reservoir bag hooked on down here, so the patient would inhale, sucking through the barrel lime, follow the hoses here, eventually to the mask. The pop-off valve is sealed. When they exhaled, it went down the other side because of the one-way valves into the reservoir bag, and then it's pulled through the soda lime. In the meantime, I'm adding 1 liter per minute of oxygen and 0.5 liter per minute of nitrous oxide, which keeps the level at a constant, about 40% nitrous. I can turn down the nitrous if the patient's getting too relaxed. And here's our pop-off valve with our suction attachment. Here was a disposable unit that worked very similarly. Here's the bag of barrel lime that we put in here. And with this, we got really low levels of nitrous oxide in the dental office. Now let's take a look at the various hoses, bags, masks, and cannulas for that matter. One company has come out, Accutron, with flavored masks. They have cherry, orange, lime, juicy fruit, and they've got a plain Jane gray one down here. And they've got a very effective scavenging system we'll talk about. Now and again, you'll get somebody who's claustrophobic with a mask and just can't tolerate having a mask on their face. And for these people, we can use a cannula that you see attached here. The bags come in a variety of sizes and shapes. Typically, they hold 3 liters. This one is pleated so it's open, and I'd encourage you to get that type of bag. If you put the mask on and haven't yet turned the machine on, there's some gas for them to breathe until you remember to turn it on. With these flat bags, they attempt to take a breath and they can't get anything, and it freaks out the apprehensive patient. So go with a bag that's pleated open. The corrugated hose that came with the machines was rubber. Because of the dust in the dental office, you would get dust down in these little ridges. It was all but impossible to clean it out. And they were costly in today's dollars, probably about $50 for a yard of this conductive hose. It doesn't need to be conductive. We're not using explosive gases. This is the same hosing that respiratory therapists use. I bought a 50-foot box, and whenever these hoses would get dirty, we'd just throw it away because I think they charged us about 50 cents a foot. It was very inexpensive, worked very well, much lighter weight than the other hoses. When you get to going around the head, I never found anything that worked better than the silicone hoses. They stood up to our disinfectant agents. Initially, we had surgical tubing, a rubber that went from the larger hose to the smaller hose. And just even wiping that with alcohol after a while, and it didn't take too long, it got very gummy. One of the things that will happen, the mask will get dropped on the floor, and assistant will reach over to pick it up and step on it, and they'll break this connecting tube here. When that happens, it's a royal pain to order one of these. You can be several weeks getting them. Take a 5 cc syringe, cut the barrel out of the syringe, and it's just exactly the right size to attach the mask to the hose. So here we go. You can see my 5 cc syringe barrels here. Most scavenging devices need a manometer to show how much suction you're getting. For the manometer to read accurately, it has to be vertical. This little ball, when it's turned on, should float up and be in the green area. If you lie this manometer on its side, then the reading is not valid. Same thing here, they need to be vertical. Here is a Porter machine that had the manometer on the side of it, and the little ball needed to float in here. That assured you that you had enough suction to make your scavenging system work. You don't need to have viral filters in these lines. There was a situation in Australia where a hospital had a bunch of cases of hepatitis B on their surgery patients, and they decided it was because the machine must be contaminated, so they passed rules and regulations that all of these hoses had to have a viral filter. It was eventually discovered that one of the anesthesiologists was not sterilizing his endotracheal tubes, and they weren't using disposable ones. Nonetheless, and I think it's still a requirement in Australia that you have the viral filter. It's not necessary. The early masks had this pop-off valve that stuck up here, and the patients would be looking cross-eyed at the pop-off valve, and it got in our way. We would bump into it. So it was a relief when we discovered the scavenging systems that didn't require a pop-off valve. This is the early Accutron system. It's a simple button here. This is suction that sucks the gas when it's exhaled through the mask from the patient and takes it out of the operatory. And it also picks up a lot of room air here. If the patient says ow or hi or how are you, they blow off a little gas, and these holes then are open when the suction's turned on. I talked briefly about the cannula for the phobic folks that can't tolerate a mask. You can get them relaxed and then slip the mask back on, and they usually do very well. If you're doing apicolectomies or you're doing little kids, you may have to go to a cannula just to have room enough to be able to get to their upper front teeth. The problem is you blow a lot of nitrous off into the operatory. It's not going to be a big deal if you use it once every couple of weeks or month. If you're using it every day, I think it is a big deal. So I'd avoid the cannula as much as possible. Here's the state of the art. The Brown mask, which was not brown, it was gray, but it was developed by a fellow named Brown. It was a mask within a mask. So the inner mask here comes our gas supply in from these hoses. Patient inhales it. When they exhale, this is a one-way flutter valve that lets the gas escape into the space around the mask, but inside the outer mask. And we have suction coming here and here to get that out of the mask. In addition, there are some holes poked down here that fit on the upper lip. And so if the patient talks, these holes down here have suction that's pulling that gas in too. And the Brown mask achieved levels a little bit higher than 40 parts per million, very, very effective. Here's a later version, looks much nicer. The inner mask pops out. It can be autoclaved or it can be disposable. They're a little pricey to throw away, but you might sell them to the patient and tell them to bring it next time. If you want to use nitrous, you're going to have to buy another one. But it's very effective scavenging. Early masks, this is a natural rubber mask that came on my first machine, and we're talking ancient history now. This is about 1967. We wiped it out with alcohol, which was about as good a sterilizing agent as we had in those days, and eventually the mask became very gummy and would stick to the patient's nose. You'd peel it off their nose, peel their nose out of the mask, and send them down to the plastic surgeon to have it reattached. So I called my friendly dental supply company and said, hey, I need a new mask. And they said, well, do you want an adult or child size? And I was seeing mostly adults. So I said adult, and this mask came. This mask was big enough you could put half my face in it. You couldn't work around it. It was way too big. And so I called them and said, you know, that's wrong. It must be a child size I wanted. And so I got this little mask, and the problem was the hole was too small. It would perch out on the end of the nose. You didn't get a good seal. So I took a look at the other mask that was still in the lab, and it had a larger hole. So what I did is I enlarged the hole here, and in fact, that child's mask then fits 90% of my children patients and uh, almost 90% of my adults. I practice in a very multi-ethnic area, and so I do have some people with some pretty spectacular noses, and we will occasionally have to resort to an adult size. But whatever you do, don't turn to the dental assistant and say, hey, go get me that extra large mask. You don't want to cause a patient to be embarrassed by their nose size. So I just asked for the adult size mask. And so what did I do? I cut 2 millimeters the whole way around the hole and another 1.5 millimeters up here. And those children's masks then work for 95% of my patients. Mark what you're going to cut before you cut it. Take your crown and bridge scissors and cut it away because it's very easy to wander clear out into this area here, and you get a mask that you can't get a good seal. You wasted your money for the new mask. This was an idea that came from a dentist down in Texas. This looks like a little Stetson hat. Here you see it on the patient's nose with the mask over it, and the problem was you couldn't get a good seal no matter what you did. Maybe an okay idea, but it didn't work. So if you bought a bunch of these, and I did, I think I bought a box of 100, they make kind of cute little Stetsons for parties. We've talked about the manometers. Be sure you've got the proper manometer and be sure that you're using the right amount of suction so that your scavenging system works. If you have assistants that are pregnant or thinking about becoming pregnant, or if you're the dentist and you're a female and you're thinking about having a family and you're worried about this, get a couple of these monitors, wear them while you're working. Open them in the morning, wear it all day, reseal it. You can open it again the next morning, get a whole week, and send it in. And particularly this variety, and there's another variety you'll see in a second, are very accurate, and they'll give you a very accurate indication of how well your scavenging is working. And remember, what you're looking for is less than 450 parts per million. And in fact, with most of these masks we looked at, you're going to be below 50 parts per million on a time-weighted average. Here's the more available one now, the Vapor Track. You can find them online, and they're probably now about $100. You peel this label off, and on it you write the date, the time you started, when you took it off, your name goes here, you send it in, they'll evaluate it. At the end of the day, you can put this back on. It seals up this part of the monitor, and you can try it for 2 or 3 days so you don't just get a one-day answer. You'd really like to know how much you're exposed to on a weekly basis. The study that David Donaldson did, well, first we can go back to this one. This was a good idea if it hadn't had the ungodly loud siren. When David sent his retired dentist out to the dental offices, they had this device here that read the exposure in nitrous oxide. These are pretty expensive machines. They're about $8,000. And then down here, they had a statistical device that averaged it out so they could say what the exposure was on a time-weighted average. You could do the same with this monitor if you bought one of these, which is way less costly, now about $3,000. But a previous machine setup I showed you, this is an expensive operation, now probably close to $15,000. So that would be another answer. Put it in your pocket and see what your maximum exposures were and what your time-weighted average was. Reservoir bags we probably beat to death. Buy the one that's pleated open. We've talked enough about hoses and how to make the connectors. I really like this polyethylene hose because it's so inexpensive. When it gets dirty, your staff doesn't have to scrub all these little ridged areas. They just throw it away and put a new piece on. We've talked kind of negatively toward the cannula. So this is my attempt at some science. Here we are inhaling, and With the cannula, about 1/3 of what you inhaled comes from the cannula. You can't get more than about 8 liters per minute through that little hose, meaning that 2/3 of your inhaled air is room air. Then when you're exhaling, the air, of course, comes out, and so that's the negative part of the graft. And as you finish exhaling, it tapers off. And then you have a second or two where you rest between breaths. During this time, the cannula is blowing nitrous oxide oxygen into the room. Down here, because only a third of your breath is what's coming through the cannula, you have to give about 70% nitrous to get an effective 30% mixture of nitrous oxide in the total inhaled air, meaning that when the patient's exhaling and resting between breaths, you're blowing off that 70% nitrous oxide into the room air. If that total flow is 8 liters per minute, you're blowing off about 0.28 cubic feet per minute of nitrous oxide into the room, or 17 cubic feet per hour. The typical dental operatory that has an 8-foot ceiling and is 8 by 10 has about 800 cubic feet in the operatory, and about 10% of that would be nitrous oxide, or around 21,000 parts per million per hour. So the cannula is really not meant to be used continuously all day, every day. You're going to have very, very high levels of contaminant in your dental office. Remember Sweeney here, he felt that we should be down here at about 450 parts per million. Anything below that was safe. And with 21,000 parts per million, you'd be way, way, way out here on this graph. And they found offices that weren't scavenging and used a lot of nitrous would see levels in the 4 to 5,000 parts per million. So it really is an issue. Here's a couple of new masks. This one is a silhouette mask. It's a nice little mask, barely as big. This is a child as their nose. You've got one little hose here bringing gas into this side of the mask, and an equally small hose serving a suction on the other side. There is no way you can pull 8 liters per minute of gas via suction through a hose as small as this one. This one is kind of interesting. It's basically a cannula. There are two tubes here that go up the patient's nares, and when they inhale, they get the gas out of those. Plus, you've got this hood here, which tends to concentrate the gas in the hood, but it's got 4, 5, 6, 7, 8 holes here into the air. So when they inhale, they suck some room air into this. When they exhale, a certain amount of that gas comes out of these holes. There is a suction hose here that goes up over the patient's head. I've tried these, and that tended to really get in the way. And just from an observational standpoint, I didn't think it did a very good job of scavenging, but they had some data here where they used a camera that sensed heat, and the air that we exhale is at body temperature, 98.6 degrees, and you can see it coming out of that mask here, out of the holes. And if you go online and find this video, you can see the little puff come out every time the patient breathes. So obviously a fair amount of gas is coming out of these holes when the patient exhales. Not all of it is being sucked up. They then showed this mask, which they called a conventional mask, which had quite a cloud of gas around it. I think somebody didn't turn the suction on, because Donaldson showed that a conventional mask with suction ended up with about 50 parts per million nitrous oxide in the operatory, and you would not see this big cloud of gas around the patient's nose piece unless somebody shut the suction off. I think this is marginal ethics in marketing. I've been pretty critical of these guys. One of the primaries emailed me and said, well, you weren't there, how do you know what we had? And I said, well, I'd be happy to attend the next time you do the study so I can see. I'll bring my own gas analyzer. And I was not invited. So this little gas, or this little mask you see here, gee, that looks great. It's got a little adhesive here that fits on the bridge of the nose. But here's the hose that's bringing the gas into the mask. It goes from here to here. Here is the suction hose. That's just too small. to suction out 8 liters per minute. I really have my doubts about this mask. The brown mask, and remember, here's Donaldson's study on a time-weighted average, was 43.4 parts per million. Ideal setting about 9. They've modernized it. The Quantiflex people have this now. It's got a clear outer shell. You can see the flutter valve working in here. Here's the outer shell. This small line is the suction line that goes into the space around the mask. The large hose brings the nitrous into the mask. And there's no reason to believe that they don't get the same results that Brown did, or that Davidson did when he studied the brown mask. And this research was done and published in the Journal of Canadian Dental Association in 1989, so it's hardly new information. So that brings us to the end. Again, if you want CE credit, you watched it, you can report that to your state board. I would check with the board and be sure that they accept it that way. If they feel they need to have my CV or my resume, I'll be happy to provide it. Let's get back to this. We have a quiz that you can take, and you send it in and I'll grade it, and that's proof that you not only listened but you paid attention. And remember, I am a general dentist like most of you, and that's my emphasis on the information needed by general dentists. But first check with your board to be sure they will accept it. It's good information. You can go to YouTube and have your staff look at this if they're ever concerned about the exposure to nitrous they get. Washington State will accept 7 hours of online CE a year without question. Oregon will accept more than that, but you have to have a test. Idaho accepts online courses. And so if you want the questionnaire, email me, fredq@comcast.net. I will email back the quiz and complete the test and send it in with $30. And it helps if you send me a self-addressed stamped envelope so that I'm sure I've got your proper address. We'll send back the certificate that you passed the quiz, and I'll send you back the quiz. And if you have any questions, please feel free to email me at fredq@comcast.net. I thank you for watching and listening. I think the next module that I'm going to post, and it'll take me a few days to do that, is going to be on the possible complications that you might run into using nitrous. Again, it's a good